Apologies. I have an apology from Joanne Dobson. Any other apologies? Okay, just a few items for information under Chairperson's business. Just advising members that in relation to the Food Hygiene Rating Bill, we had invited Fermanagh District Council and Ballymoney Borough Council to present oral evidence. Both councils have advised that they're content that their written submissions cover the points they wish to make. So therefore the next step will be an evidence session with the Food Standards Agency on the 11th of February to discuss the evidence we've received through our written and oral evidence. Also, just advising members that the Minister has written to the committee this morning to advise that he's going to seek executive agreement to the Secretary of State for Health in London, making regulations on behalf of here to introduce standardised packaging of tobacco products. The papers will be provided in next week's packs. Item 3, members, is the minutes of the meeting of Wednesday the 21st of January on page 6 and Monday the 26th of January at page 3 of your tabled booklet. Can I ask our members' content? Great. Item 4, members, is the expert examination of the HSC governance arrangements, the briefing from Sir Liam Donaldson and departmental officials. Advising members, as you will be aware, the Minister made an oral statement on this matter yesterday and the report was published. The statement and report are at page 6 of the tabled booklet. You're very welcome.
Thank you.
Delighted that you could attend today. We have with us Liam Donaldson, the report author, Mr Richard Pengelly, Permanent Secretary, Michael McBride, Chief Medical Officer, and Charlotte McArdle, Chief Nursing Officer. Just to advise yourselves, we're talking about structuring this into two parts, if you like, in terms of the way forward. We want to begin by focusing on the report and direct our questions to yourself, Liam, in relation to that. We'll then move on to discussing how the Department intends to respond to the report and direct our questions to the officials. I do want to say from the outset that, you know, when we have a question directed to the Department, it would be our preference if one official would answer. So if there's a judgment among yourselves as who's best placed to do that, but it's certainly in terms of maximum detail and outcome would be our preference. So you're welcome. I'm going to invite yourselves to make the opening remarks and then we'll open it up to members' comments.
Thanks very much, Chair. I just want to say something very, very briefly by way of introduction, Chair, and then I'll maybe ask Sir Liam to say a couple of words and then to allow the committee to move into the questions. The only point I wanted to make, Chair, and I think it was one that risked being lost a bit yesterday, was just taking us back to the early part of last year when the report was commissioned. This was in specific response to difficulties at the Belfast and Northern trusts, which had been highlighted as serious adverse incidents. And at that stage, Chair, there were many concerns about the transparency of the system and whether in fact there had been a cover-up around those issues. I think the important point, and Sir Liam might want to say a bit more about this, Sir Liam provides us with a reassurance that he found no evidence of any form of cover-up, and there's also clear evidence in the report of staff striving for transparency, notwithstanding the intense scrutiny which they're under. So I just thought that was an important contextual point to bring to the fore of our conversation today. Other than that, maybe ask Sir Liam if you want to.
Well, thank you very much, and thank you, Chair, for inviting me. It's a good opportunity for me to talk a little bit more about the report and answer your questions, so thank you. As the Permanent Secretary said, the initial purpose was to provide an external view on the internal procedures that were used to investigate and report on some of the concerns about standards of care in particular trusts. But the terms of reference were wider than that. They were to look also at the quality and safety aspects of the health and social care system in Northern Ireland. And it was in pursuit of a rounded view, not just on the specific issues where we were able, as the Permanent Secretary said, to provide reassurance, that in talking to a large number of staff and stakeholders and patient representatives, it was clear to us that quality and safety in the service was determined not only by matters to do with the investigation and action on serious adverse incident reports, but also on the structure, processes and organisation of the health and social care system overall. There was nothing shocking in this that you wouldn't find to some extent in other parts of the UK, but I did feel a great surge of optimism as I concluded the work, that the size of Northern Ireland, and I think the dedication and commitment of the staff in the front line, does give the opportunity to do something that in a larger, more complex health and care, social care system would just not be possible. And I think there is an opportunity for Northern Ireland to move forward relatively quickly and address some of the things that other countries have not been able to solve. And I believe the 10 recommendations, and I deliberately kept the number small, are genuinely capable of being transformative. If all of these recommendations were acted on, and they come with my 30 years experience of healthcare, safety and quality, my leadership in another part of the UK of a healthcare system, and my extensive knowledge of across the world of other healthcare systems, and my US advisor coming from a position also of around 30 years experience as a physician and quality and safety expert, and somebody who was presiding over probably one of the most successful institutions in delivering healthcare to 8 million people in the United States. So we have provided a diagnosis, much of which you'll recognise, but it is an externally validated diagnosis. But we also, I think, have opened some doors and some opportunities, and I would very strongly hope, as a person who has great goodwill towards the country of Northern Ireland, where I have some ancestral roots, that you will take those opportunities and become a service that is leading others rather than the middle-of-the-road position that I believe the service is now in.
Okay, thank you for that, and thank you for your work. I think it's important to say that also. And I think you'll find no fault around this table in trying to deliver that first-class service that we all strive to achieve. But I think we need to chase, particularly in terms of recommendation 1, which clearly says to recommend that all political parties and the public accept in advance the recommendations of an impartial international panel of experts who should be commissioned to deliver the population the configuration of health and social care. What evidence was that based on?
Well, it was based on a reading of previous documentation where others have made similar comments about the distribution of facilities in Northern Ireland. It was based on a universal message from the relatively large number of staff that we talked to over a short space of time, that they also felt that the current arrangement distribution of health facilities in Northern Ireland was not what the population needs. And I think a very strong feeling that behind the scenes everybody would do it if it didn't cause them any personal injury to their reputation and position. It's purely, in my view, a problem that I've seen elsewhere in the world, where there are widely distributed populations. In one of the states of Australia in particular, where I did a review, exactly the same issues prevail. The local populations want the specialist services close to their doorstep, and the local politicians are afraid of being voted out of office if they oppose changes, albeit evidence-based changes. And then thirdly, the emotion and the campaigning is all on the resistance side. On the evidence-based side, the clinicians and others who, behind the scenes, strongly advocate change are not prepared to go into campaigning mode and use some advocacy. So you may say, Chair, and I would be reluctant to feel that this was the dominant feature of the report, because I think the 9 other recommendations, particularly the ones on the voice of the patient, where I think Northern Ireland is in a very weak position and could strengthen its position, are capable of transforming the quality and safety of care. But finally, if you were to say to me, in all honesty, as politicians, that you believe this problem is insoluble, then I would have to stand back and say, well, maybe some problems are insoluble, but it would be very, very sad indeed for the population of Northern Ireland.
But I think there's a number of things in that. Firstly, you've identified in your report that the system isn't the one we need. And that's fine, and I have no difficulty with striving forward to take that on head on. And I agree with you that the sector and medical professionals and staff will indicate that as well. However, the question that I'm asking is that have staff and medical professionals told you or accepted or advised you that an independent panel of experts will be commissioned without consultation that the public should agree with in advance?
No. The diagnosis that I made, the need for change, was based on partly on the discussion with staff, but the recommendations are my own, based on 30 years of experience, and particularly 12 years of experience in a major policy-making post elsewhere in the UK, where I had to think a great deal about how to achieve change. And this is a recommendation which is high-profile and, I admit, likely not to be accepted. But I think it's a very great pity, because I would say, where is Plan B? And if I was a gambling man and said, well, if there's no Plan B, then I would put a lot of money on this never happening. And the implication is you're saying a 2-tier service in Northern Ireland is the standard that we want to set for our population's care, and a solution which will take it to 1 tier of a high uniform standard is insoluble for political reasons. OK, but just come out and say it openly.
But nobody's saying that.
But that's the implication.
I think that the important point in all of this is that I'm asking you a direct question around: have the public, the health sector, the professionals signed up to agreeing in advance with recommendations? You know, you talk Plan A, Plan B. We don't even know what Plan A, Plan B are. To sign up to those recommendations in advance. I mean, it turns, in my view, the whole process of, active consultation, participation, making sure we have a strategic outcome to transforming your care, and looking at health inequalities and outcomes. So we are effectively being asked here to, or it's been indicated here, is that people, the public and medical professionals and people working in the field in the sector agree in advance to recommendations from a panel of experts.
Well, I think what the recommendation is really saying is that the agreement should be that if an evidence-based blueprint for the service in Northern Ireland, which accords with best international practice, is recommended, that people would not shy away from that without good reason. And good reason is not an emotional perception that this wouldn't be a good thing to do for a variety of reasons. And we've seen the benefit, particularly, even though it's still controversial, your review of paediatric cardiac services brought in an external panel. And it seemed, it may not have done the job, but it seems that people were willing to set aside some of their personal opinions on it when they saw a distinguished panel coming in and giving it. So it was to recommend a similar approach to that, and I accept that ultimately the decision's still got to be made by the Assembly to sign it off. But people should not, we should be trying to get people to agree in advance that they would take a reasoned approach, and by and large, if the evidence was strong and compelling and acceptable, that they wouldn't find reasons to undermine it. I think that's basically the spirit of the recommendation.
Okay, but I mean, I would take issue with the fact that what's been recommended is accept in advance. And I think that that's a step way too far. I accept what you're saying, that processes need to be evidence-based, and of course they do, and getting the right outcome. But, you know, a recommendation such as this, in my view, is a step too far.
Okay.
Secondly, just if I may, in terms of commissioning, just so I'm clear, did your terms of reference specifically ask you to review or assess the commissioning process?
They asked us to look at the systems for assuring quality and safety, and as I say in the report, our view was that this has a very strong bearing on the quality and safety of care delivered. It needs to be right, it needs to be reinforcing good care and safe care, and at the moment we can't see how the commissioning service works.
So is it not safe at the minute?
It probably is most of the time, but we can't see how the commissioning process and decisions flow through to provide those assurances, and a very complex system that is very difficult to understand.
I just had noted as well that on page 15 of your report, you had referred to it as imperative somewhere in the system where needs to be assessed, services planned and funds allocated. I suppose directly, are you then suggesting that by implication in that statement that neither the local commissioning groups or the Health and Social Care Board are actually assessing needs and planning services adequately? Is that?
No, I think what I'm saying is if you make changes and simplify the process of commissioning or any other way of arranging care in Northern Ireland, then these are givens. You've got to make sure that you can show that those things are being done properly.
Okay, and I'll finish at that point because I want to come back to the department then in terms of that review of commissioning. So there's a number of members have indicated. I have Kieran first.
Chair, thank you very much. And just to follow on from the recommendation 1, I mean, I hear what you're saying there, but what you're in fact is saying closure of a number of hospitals.
I'm not saying that at all,
no,
sir.
You're not, but that's what you mean.
No, sir, I'm not saying that at all. I am saying, if you want me to be really honest, I will say I'm not sure these days you could get a consistent definition of what a hospital is. Could you define it?
Well,
would you like to give us a definition of a hospital as you've raised the question?
All I can say is that when you talk about closing a hospital, you will have the fury of the population on our backs, on everyone's backs, and the Minister in his response to me yesterday actually on the very subject, he simply wasn't prepared to accept. He did say that we face uncomfortable decisions. That was obviously meaning going on from transforming your care to close some local hospitals. And this is what I take out of recommendation 1.
Well, I don't accept that. I don't accept the concept of closing a hospital because I don't understand.
I'd like to hear that.
And I would like to have. The premise of your question is that if something's going to be closed, you said it's a hospital. I'd like to hear your definition of what a hospital is. But I would say to you that in the modern world of healthcare, health facilities take all sorts of different forms, and there's no question that what would be replacing anything that was changed in your system would be an advance and an improvement on what had gone before.
So we can relax that you're not suggesting closure of small hospitals.
I think you can. You'll have to accept what I say, that I won't be drawn into defining what a hospital is, because I don't think anyone can. But what I will say is that the range of health facilities in Northern Ireland, including hospitals, would be better for change than it is at the moment.
can we move on then to the evidence on which your findings are based? There would appear to be a number of findings in the report that are based on opinion rather than purely facts. For example, on page 10 of the report you state, however, senior executives in the Northern Ireland care system are now paid much less than their counterparts elsewhere in the UK. The public would be better serviced if their care system could compete to attract the very best managerial talent. On what evidence are you making the claim that the public would receive a better service if managers were paid more?
Well, because having had extensive experience of management in healthcare, having been a chief executive myself in the northeast of England, I see a huge variation in the standard of managerial performance. And these are people who are not running mobile phone companies. They're running organisations that determine whether people live or whether they die. And therefore, I think it's a short-sighted view to say that you keep the costs of this down to the bare minimum. And I believe that these are important, responsible jobs, and the rates of pay for them should be comparable to other public sector posts in other parts of the UK that serve the public in life and death and high-risk situations.
So it's not an opinion, it is fact. You're saying it's purely facts, that if we had better paid people to do the job, we would have a better health service, rather than an opinion.
It's a skilled professional judgment, it's not an opinion.
Right, okay. All right, Chair, thank you at the moment.
Thank you, Kieran. Michael? Michael?
Okay, thanks, Liam. And can I say, we've never met, but many's a time I sat at Cobra listening to you talking away about swine flu. That was quite a challenge. Unfortunately, it didn't translate into what we were at one stage anticipating, 15,000 premature deaths in Northern Ireland alone. But I have to say, Chair and colleagues, Liam's advice was always very carefully listened to, and he played a very important part in all of that. Am I right in thinking, were you involved in the City Hospital Maternity Royal?
I was, yes.
I thought that,
yes,
you were part of that. I seem to remember that as well. You start off with saying that is the situation insoluble, or are we looking at a two-tier? I don't believe for a minute this is insoluble. I think the system is under some stress, and I think we don't appear to have enough beds manned to take sick patients. We don't appear to have anywhere for well patients to go once they've had their treatment. We have, under the new regime that's been in now for some time, most of our GPs don't work nights and weekends, and that's promoting a lot of stress in the system too. And the fact is that the Northern Ireland Health Service is underfunded vis-à-vis England, Scotland and Wales. And in fact, in 2009, we fell behind England. We've always been behind Wales and Scotland. We fell behind England in 2000. I don't think we're making that up. So we're starting from a way back. So it seems to me that, and it's an observation, we're getting into questions, you have a system, you need a certain amount of money to run the system. If the money's not there to run the system, you either up the money or you drop the system. And I'm concerned that you're getting involved in around there, that we're going to end up with a system that matches the budget, rather than what we need, which is a system which matches needs, which I think is where you're coming from. And I'm a great believer also, I have to say, in evolution, not revolution. What sort of time frame do you think we're looking at? Say you get all these recommendations, and I have to say the first one about we'll all sign up to it. I mean, frankly, in the real world, that ain't going to happen. I know you would like it to happen, it isn't going to happen. What sort of time frame do you think we're talking about to evolve, to get ourselves a system that will actually meet the needs of the people of Northern Ireland? Because I actually think our health service here is a good health service. I just think there's problems, and I think those problems can be fixed. But all right, the model is not quite what we want. But I'm thinking of the time frame, because of some of the fairly negative headlines you've been getting so far. What time frame are you looking at, and what sort of bill do you think what does the money need, which is also the key thing that we have to wrestle with in here.
Well, I think, first of all, and thank you very much for your comments, I think, first of all, you're not alone. I think I'm not a person that could judge the relative level of funding. Maybe others can, but I can't. I haven't looked at that. But what I would say is that notwithstanding the 2008 financial crisis and the effect that that's had on public services across Europe, really, there was already a funding crisis before that. And the funding crisis was that most health ministers that I've encountered in developed countries around the world were concerned about how their service would be sustainable in the long term because of growing demand, ageing of the population, and all the factors that we know about. So there are two issues here. One is the fixing of problems, but the second is the whole question of sustainability for the future. Now, my report wasn't asked to look at public health, but it would be wrong of me not to draw attention to the high levels of preventable disease in Northern Ireland and in many other parts of the UK as well. And those upstream factors will be major determinants of the sustainability of the health service. As far as fixing the problems are concerned, I think that as I said at the beginning, some of these recommendations are transformative, potentially. And I do think, despite the question of funding needing to be resolved, that there are things that can be done to innovations, creative ideas, which could make a service do more for the money that's available to it. And some of them are set out in the report. But many of the recommendations will do one other big thing. They will make the service much more patient-centred, because at the moment it isn't. I would say the service in England isn't either, and I know that very well. It is not truly patient-centred, and that is, I think, of anything, would make everybody feel a lot more positive about the service if some of those changes came in.
Thank you for that. Just another part of it, which I think is a key, and we don't talk about it an awful lot here, and that is the independent sector. Because the reality is that the service just doesn't have capacity in a whole number of areas, in orthopaedics, ophthalmology, for example, and there are others. And we have huge waits now developing some of these. And it's the role, now, it seems to me the only way you're going to sort those waits out, because your journey time in England is 18 weeks, our journey time now could be over a year. That's not acceptable. The only way we can sort that out is actually in the independent sector, and we've paused that 6 months ago. So it means when that unpauses in April, first thing you've got to do is take care of that lump, all those waits, before you get into the waits here. And you're probably talking about very large sums of money to actually get us back to where we were, because once you start to let this go, pulling it back is very, very expensive and very, very difficult. In your model, and I take the point about what is a hospital, and how do you define it, and where our acutes are, and so on and so forth. What role do you see for the independent sector? In England, you're spending about 6%. Over here, we're down 1 or 2% on the independent sector. But we ain't going to get her back to where she should be without some money for independent sector.
Mm-hmm. Well, it can be successful if used in the right way. Obviously, the factors that need to be borne in mind are: does it, by making a short-term commitment to buying the independent sector, does it cause any difficulty for the infrastructure on the NHS side, which may be needed in the long term? That's the first question. The second question is it the same surgeons working in both sectors, and is there any conflict of interest there? And then the third issue, and I did hear anecdotal concerns about this expressed when I was going round, is that in some of the crisis situations where a trust was under pressure to get its waiting times down quickly, they felt they were paying over the odds and not really getting good prices for the services they were buying. But it does have its place. It's been successfully used in England. Obviously, there are things that need to be taken account of.
But you would operate presumably within the tariff, whatever the tariff is, in the
Yes.
health service. You would operate within that. So the health service globally, it's not costing any more, say, to do a hip or a knee or a...
Yeah, but you don't have a good tariff system here at the moment,
Yeah.
really. No.
Okay,
Thank you.
Nicky?
Yeah, thanks for the presentation. My questions are around transforming your care.
Yes.
Recommendation 3 states that a new costed implementation or timetable implementation plan for transforming your care should be produced quickly. In evidence to the committee last year, the Royal College of Nursing described transforming your care as a vision without action. And I think you're recommending that that plan should be produced as quickly as possible. Were you asked to review the implementation so far of TYC? And the second question is also in relation to recommendation 3, where you have suggested that there should be expanded roles for 2 groups, pharmacists and paramedics. Is there any particular reason why those 2 groups were chosen?
Yes. Well, thank you. Insofar as I've gone into wider territory, it's purely because I found that there were several things, including this, which had a fundamental bearing on the quality and safety of care. So in other words, if patients are flowing into the health service in high numbers, putting pressure on the system, then the staff in there are less able to cope and deliver standards of care. So if you take a step back, you look at the root cause of that. The root cause of it is a slow pace in developing those services which upstream would prevent the pressure, and the pressure is what's causing the doubts about quality and safety of care. So I wasn't asked to review transforming your care. I was asked to review quality, and I thought it had a contribution and important bearing on that. Why did I choose those 2 examples? They were examples. In my discussions with the Ambulance Trust, I asked them about their innovations, what they were doing to improve the quality of care. And they gave the example, they cited the number of patients admitted as emergencies to hospital who were diabetics who went into hypoglycemic coma and shock. Their blood sugar fell. 999 into hospital, sat in the A&E department for a few hours until they were stabilised, and then they were sent home. And they had the idea of extending the skills of their paramedics so that they would go to the patient's home in such a situation, take a blood sugar level, give the patient the glucose they needed, wait half an hour, take another blood sugar level, do exactly what would be done in the A&E department, leave them stabilised, and avert all of those people going into the A&E department. I thought it was a great idea. And they'd piloted it, and it seemed to be work. And I said, right, why don't you just now do this permanently? You've changed the process of care for the better. Why not institutionalise it? And their response was, we can't get cooperation from the trusts. We're not legally in a position to bear the risk of managing those patients on our own. What we need is the hospital to agree that we've done what we've done, and they will arrange an outpatient appointment in the next week for that patient to review them. And I said, well, have you achieved that? And they said, no, we can't get agreement between the trusts to do it. So we're contemplating abandoning the programme. And I thought that is a classic example of people working in silos instead of working together. So if you like, I was being a bit provocative. I was saying, if I recommend this and the government accepts it, then they will have to confront the fact that these good ideas, which could help to release the pressure on hospitals, would have to be addressed, and people would have to confront the fact that they're not working together. Pharmacists, on one of the trusts I visited, the duty pharmacist told me that 4 of the patients that had been discharged over the bank holiday weekend, where he had to do the prescriptions, 4 of them had been given 20 drugs each. Now, in medical terms, that is absolutely shocking. People should not be on regimes of that sort. Their medicines should be reviewed, and but the pharmacist was powerless to do anything about that. He's not a doctor. How can he do anything? And so I felt, well, there's another good example which will challenge the system to show how they can work together. So if you like, I was being provocative, but I'm pleased that I am, because I think things need to change, and these examples are good ones where people have great ideas that would be transformative, would improve care, but they're hitting a brick wall because people are working in silos.
Thanks for that. I mean, the ethos, or part of the ethos of transforming the care, was to do what you're saying, prevent people from getting into hospital, remain in the community. But obviously infrastructure has to be there to deal with that.
Yes.
Because the shift left hasn't really happened from acute to primary in terms of the funding. We were told, I think originally, something like 83 million was going to move from acute to primary. That hasn't happened. So obviously a costed, timetabled implementation would need to happen quickly, because transforming your care has been rolling along or tumbling along since 2011 without any foreseeable outcomes. And I think that was part of the problem. When it initially came out, outcomes weren't part of the overall plan. At least that's the way it seemed. The 99 recommendations, if you went through them one by one, they all seemed fine at the time, or most of them, but it simply hasn't happened. So
well, I think that word, that phrase, shift left, was like a red rag to a bull to some of the people I talked to. I spoke to a very courageous woman who was a carer, and her son had, very serious levels of disability. And when I mentioned to her that this policy would improve, she went ballistic at the use of the term, or even the term transforming your care. And I think it's a great vision and a great policy, but people don't have confidence in it. And the GPs were also very negative, because they felt that, and again, it was dysfunctions in the system, because they said, well, people are being sent out, we haven't got the referral letters, we don't know what medication they're on, we ring up the hospital, we can't get to speak to the consultant or even a junior doctor. And what some of them were doing was ringing up a colleague general practitioner who happened to have sessions in the hospital and say, could you go along and find somebody I can talk to? And to me, that was something that IT could help with that. I mean, it could be a great help if electronic communication came in. But there's basic practical problems about how the connections work between the system, how the communication works, how the processes, which are soluble if people sit down and really look at what's dysfunctional and solve it. But there were so many stories like this. I'm sure it would be no different in England, but if you wanted me to put a label on the NHS across the UK, I would say at times it is extremely disorganised and just needs to be better organised.
I think the problem, the shift left, possibly had political connotations for some people. Maybe that's where the problems arose. But thank you. Thanks.
Paula?
Okay, Chair, thank you. Excuse me, I just hope my voice...
You've got a friend here who's here.
I just want to follow on, actually, before I come in to talk about recommendation 4, probably ties in with that as well, what Mickey was talking about earlier, and you mentioned about some good ideas to release the pressures in hospital. And I know through my own personal experience and other people who live in my own house, some of the wonderful clinicians that we have within our service that are coming up with the most innovative ideas to release people or to discharge people from hospital for care in their own home, and a lot of them are not feeling supported though as well. I know from somebody in my own household who was released from infectious diseases ward last year on a fantastic acute care at home programme which saved weeks of bed days in hospital. And quite often the clinicians are not getting the recognition for the work that they are doing. So I mean, we need to put that on record as well. There's some fantastic ideas some people have that really will make a big difference to our length of stays in hospital. And I suppose that takes me on then to do with your recommendation 4 and the self-management of chronic illness. And I don't think anybody would disagree with the recommendation there that people should be empowered to manage their own illnesses. And I know again from personal experience, I worked in the respiratory ward in Antrim Area Hospital for 3 years, and the amount of COPD patients that we had in that were just completely revolving door patients in week after week, and with the same problems that could have been maybe dealt with in their own homes, that would have avoided admissions into hospital. But on that, can I just ask, are you aware that under the programme for government, one of the department's commitment, which was number 44, is to enrol people who have chronic conditions in a condition management programme? And are you aware of that, for example, that's
I
already
didn't
there?
know about that.
Okay.
I met the organisations responsible for the representatives of the British Diabetic Association and others, and they were a very well-informed group. They didn't actually mention that, but they also were not particularly involved in the commissioning process particularly, and I thought, certainly when I was in England and I suggested something to ministers at the time, which wasn't adopted, I think it was probably too radical at the time, that I suggested that in some fields of care, these voluntary organisations, charities, should commission the care. So why shouldn't the British Diabetic Association commission diabetic care, obviously with professional advice? And I think, well, I just think I've seen evidence elsewhere in the world of people getting the support and skill to manage their condition, and they don't need much. I mean, there is no mother of a diabetic child. I would defy you to catch them out on something they don't know about with diabetes or the management of their child. And that's what we need to tap into, rather than the sort of attitude that one person told me about, which was he'd been a diabetic for 40 years, and you'd expect after that length of time that he would have eye complications and skin ulcers. He'd had nothing. There's no complication. And he was in for his annual visit, and he proudly went to the consultant and said, I just wanted to let you know I've been insulin-dependent diabetic since adolescence, and I've controlled my condition myself, and I have no complications after all this time. And the consultant said to him, you're very good at following orders. And it's that balance of power that needs to change. It's a partnership. It's not the patient down here and the healthcare professional up here. And that's what that recommendation is all about.
I also think as well it's given the patient the relevant information so that they don't fear that they can manage it at home, that they do have the ability to manage it themselves, and it's giving that information to empower that patient to make those decisions. And I think we fail on those levels.
Well, I'm sorry to get excited about this, but on the way up I was brought up by a taxi driver, and he spotted me from the attacks that had been going on in the newspapers, and he said to me, you're reviewing the health service. He said, I've got something to tell you. And, I had a stomach problem. He said, I was treated for 7 years with these Zantac type tablets, and I saw a locum, and he said to me, look, you could have the commoner cause of ulcer, Helicobacter pylori, gave him a week's course of antibiotics, and he was cured. But the point of the story was, he then went on and advised 3 other taxi drivers that had had similar symptoms for that length of time, and all have been cured. So there you are. There's the expert patient for you.
That's our expert
Not a model to be
drivers.
recommended, but an interesting story nonetheless.
But just, I mean, there's already been work that is being done by the Public Health Agency and the board
Yes.
on the management
Well,
of
we should
chronic
build on
conditions.
that.
So it's to build on that
Yes.
and work in tandem with
Yes,
that.
definitely.
It's not to build another
No.
tier. It's to work in line with
Yeah, and
what's
bring the
already
charities
being
into
done.
it. Yes.
Yeah, okay. And as I say, I don't think anybody would disagree with that. Again, around the terms of reference, was this part of the terms of reference, again, to look at
No, it was not to look at that, but it was to look at things that had a bearing on quality and safety. And more or less every major report on quality around the world, Don Berwick's one in England recently, emphasised the fact that engagement with patients and families directly in various aspects of their care was the bit of the healthcare system around the world that was not working well, and it had potential to have great benefit.
Okay, thank you.
Just if I might, Paula, on that, I mean, are we now that recommendation 4 isn't a recommendation? Because just to be clear, because there is work ongoing commitment in the programme for government, so we don't need to establish what's been suggested there. A programme should be to give people with long-term illness that opportunity to manage. Well, and I would just make the point, because I absolutely agree, Liam, in principle with what you're saying. The difficulty, and maybe Richard will come back when we move on to the department, but you know, we've had even like a self-referral pilot that was initiated in terms of physiotherapy, and then it was just pulled. So you know that you're absolutely right, that process, which is all part of your shift left. But the reality is we have a commitment in programme for government, and now we're saying this potentially could be duplication, is the point that I'm making.
Well, I don't think you see, I've worked, don't forget I've worked in senior governmental role myself. Any report to government is responded to, and some of the response is accept as recommended, some of it is reject as recommended, but quite often the response is, well, we've got something going on this, we're going to reshape it, re-energise it, and we will meet your recommendation in that way. I mean, that is the way the world works. And we went over a lot of ground in a very short space of time in a field in a country that we didn't have the detailed knowledge. We will have missed some things. I wasn't told about that particular initiative, but you know, there were hundreds of things we came across. So if there's something already going on, I think that fits into the category of what I would expect an executive or a government to do, would be to respond and say, well, we're already doing something a bit like this. Let's bring the thing together. But what I have suggested, which is a sharper edge, is that there should be proper evaluation, that there should be metrics, because there's no point in empowering people to manage their own condition if we don't then learn whether it's working and whether they're getting lower rates of complication, higher quality of life, than if we just left them being dealt with in the old way.
Particularly, I suppose, if it's a programme for government commitment as well, but points well made. Rosie?
Okay, and thanks very much for the presentation. In a general sense, before I ask the question that I'm going to ask, and I suppose in ways they are related, but how problematic would you say within the system this apparent failure to think outside the box, or to you know, to look at like new ideas, or to accept change? I mean, how problematic would you say?
Well, it is a problem everywhere. Inherently, a lot of health services, social care systems, there are conservative elements with a small c, people that don't want to change. But the whole movement for quality improvement, which is very strong in some places, tends to encourage people to have an appetite for change, and based around looking at opportunities for improving things. So I'd say Northern Ireland isn't any worse than anywhere else, but I think, with no disrespect to my generation and my age group, I think we should look to the young doctors and nurses for the future. And I think getting them to realise that being a doctor and a nurse is not just about treating the patient in front of you. That's very important. But it's also about thinking more widely about how you can make your service better. And I think that it hasn't, in my generation, that was not a professional value. The professional value was to do your very best for the patient in front of you, not to think any more widely than that. And we know that people that think more widely make a contribution not just to the patient in front of them, but to potentially dozens of patients in their care.
Okay. In terms of recommendation 5, it suggests that the RQIA role could be replaced by outsourcing the function to the Scottish regulator, for example. Could you provide more detail on the sort of thinking that lies behind that recommendation?
Yes, well, as I say elsewhere in the report, in our discussions, the RQIA was not mentioned once by anybody or any organisation as they just didn't mention it spontaneously or talk about it. And that would be in England or in America unheard of. The Care Quality Commission in England is a dominant feature. I mean, not in an entirely positive way, because, you know, it does introduce a fear factor that sometimes isn't always helpful. And in the United States, the Joint Commission, which is their main accreditation organisation, which can make or break a hospital, really, in their market, is also on everybody's lips. And it was just puzzling that in Northern Ireland, the regulatory function in health, it was prominent in social care, was not spontaneously mentioned. So, having looked at it, the Minister at the time had just announced that he was going to bring in acute hospital inspection, which I think is a good move. But that seemed to be an initiative which didn't necessarily have a wider context to it. And so we felt that it would be time just to look at the health side of regulation in the round and say whether you feel that, whether Northern Ireland feels it's right. And though one or two people suggested, well, are we big enough for a regulator of our own? And wouldn't there be an advantage possibly in looking to some a regulator in another country that had been longer established and would have data that we could compare ourselves to in that country? And that's, I mean, for example, the Joint Commission in the United States has a branch called Joint Commission International that helps with regulation in quite a lot of countries of the world now. So it's a model that's in use worldwide. There are advantages to having the regulator in-house, but there are also advantages to having the regulator external and working within the country, but not based in the country.
And are there particular elements of the Scottish model? Are you very familiar with it that makes you feel, or is it just a proximity?
I'm not deeply familiar with it, but it was something that people felt that it was relatively near at hand, and seems to be a mature and good organisation. It was just I think if this is going to be if this recommendation is accepted, then I think all the potential options need to be looked at, and that was just an illustration.
Okay. In terms of recommendation 7, the creation of an Institute for Patient Safety, can you elaborate a wee bit more on that? And
yes, I'm pleased you mentioned it. It has not been raised with me once in the last 36 hours. But I feel that one of the key areas that I have experience in and I've looked at in the last few years since I've stopped being Chief Medical Officer, I've spent a lot of time on the subject of patient safety. I've read 10,000 incident reports in England. I have analysed them. I have listened to descriptions of incident reports in two of the trusts in all of the trusts in Northern Ireland, but in depth in two of the trusts and discussed them with staff. I've looked at incident reports in several other countries of the world, and the fundamental flaws in any system, I won't list them all, but the two that I would say are directly relevant to your question are, firstly, that the quality of the investigation does not always lead you to the true cause, because expertise which is very valuable in other sectors, particularly the so-called human factors element of things, tends not to be used a great deal in healthcare. And if it was, then you would get closer, I think, to the true causation. And then I've seen no strong examples around the world, in England or in Northern Ireland, of learning which leads to a definitive reduction in a risk which then is sustained. So the same things are happening everywhere, and they're happening over and over again. And I felt that this is it's sufficiently important because some patients are seriously harmed, some are dying, that it needs to be somebody's day job. And it needs to be taken very, very seriously. The data need to be analysed in a much more sophisticated way than they are at the moment. We need to get people that can come up with solutions that will actually work. Because at the moment, there is a bit of a feeling that this is about documenting incidents, not finding solutions that work. Hard though everybody's trying, there's more to be done.
So how confident would you be that a more holistic approach to diagnosis would be adopted?
Well, I don't know I can't be confident that recommendations would be adopted because I've seen the force of against some of them, but I'm confident that this would give you a much better chance of reducing harm and saving lives than the present way of doing things, which is basically several organisations working on this at once.
So in effect then this would take over the function of the serious adverse incidents?
It would,
function?
yes.
Okay, thank you very much.
Thank you. I think we're moving on to questions to yourself now, Richard.
Could I, just before you move on, from Liam,
Yes.
Following on really from that, it's your recommendation 10 is to do with the patient-client council. Now you're saying, you're not saying anything derogatory about the activities of that, but you're saying that you would advise of more independence for that body.
Yeah.
What's your thinking behind that? Because I would have thought that we have a fairly good patient-client council and complaints department here. What's your thinking on that?
Well, firstly, I think they're very good people running it. I didn't feel that there was as much representation of actual patients and users of the service on the board as you would see elsewhere. And the patients that we did talk to, and we talked to some who suffered harm, families, when we talked about the patients, they were very respectful of the people that are running it, of the board, but they said they're inside the system. And, you know, we would, and then on the complaint side, I think if you would find that a lot of complainants are dissatisfied that they don't feel they've had a truly independent view of their complaint.
Right. So an independent voice, yes, would make the difference.
It would.
That's yes. Okay, Chair.
Okay, there's actually a few more comments to yourself. Liam Fergal first.
Thank you very much, Chair, and thank you, Sir Liam, and for your considered input. For me, this report illuminates the health landscape, and as a result, really shines light on some areas and throws up shadows in dark areas elsewhere. And you make some criticisms of constituents attached to the overall service and those who use it. But would you accept that, in terms of the media and public and politicians, you've ascribed particular motivations to their interests, self-motivation, self-interest? But would you accept too that their other and perhaps maybe more primary interest is accountability, and making sure that those who are making decisions are making it in their best interests?
I completely accept that, and I certainly mean no disrespect to politicians. I've worked with politicians extensively in England. I understand politics, and I understand how difficult sometimes it is to balance the needs and wishes of constituents against perhaps a wider policy debate, which is controversial. I completely understand that. I think yesterday I allowed the comment to go unchecked, which was made by one of the journalists that I'd criticise the media. I actually didn't criticise them. I just said that the reporting is generally very, very negative. You see that, I see that in England as well, and, but it's not quite as negative as it is here. And I do think that sometimes continuous negative reporting gets to be a bit of a habit, and I think it can be very, very demoralising for staff, and I think it can undermine public confidence. And so it's not a criticism. I mean, I would be the first, when my colleagues in Whitehall behind the scenes used to criticise the Daily Mail and say this is terrible, so I would always be one internally in those discussions that would stand up and say, I'm sorry, I've had a hard time with them as well, but on balance, I'd rather have a media that has no fear or favour. I definitely believe in that. But I do think there is sometimes a balance, and we would not see in England this level of imbalance in the coverage, and that's really what I'm talking about. And I do think there is sometimes, you see, I've quite a subtle, some subtle thoughts on this, that in my experience of dealing with the media on health topics, the tendency is always to go to black and white. And my job as a professional when I was in post was always to show there are shades of grey, and you need to think about the shades of grey, not just the black and white. And what I see here, everything's painted in black and white. There are no shades. It's as if there is no colour grey in Northern Ireland, which is good in some ways, but grey isn't a great colour. But that is to me frustrating. I'd be very frustrated if I was a doctor working in the health service. Very, very frustrated. So I don't mean to say that the media fault or that it's unhealthy to have media involved at all. I'm just saying that the phrase was very carefully chosen. A system under the microscope, and it is. And there are disadvantages in looking at things only through the microscope because you don't see the big picture.
Yeah, and with respect, I would suggest that you're looking at the symptom and not the cause, because we see it repeated because it's reacting to repeated actions taken at leadership level. Do you agree?
Well, you've been looking at it for longer than I have. I couldn't comment on that. I don't very often say I can't comment. I don't feel well informed enough to say that that is the root cause of the problem. I don't know.
Yeah, but you also point to the failure in the administration in terms of how things have not been implemented, and of course that has led to bigger questions around accountability. So how could you be assured that those who failed the system in the past at managerial and high levels within the system are in any position to fulfil the ambitions that you want?
Well, I think some of the failure is of an overcomplicated system for a country so small, and I think I would like to see the governance and accountability simplified and much more clarity about the leadership, and I think that's probably as far as I could go in my knowledge of the system.
But would you accept that this has been strategic failure?
I don't think I'd use a phrase like that about it, no. I think it's, as I say, I've seen other situations around the UK which have got bogged down in a similar way, trying to make change in very difficult environment, very difficult circumstances, and it's just very, very complex, and I think you should be looking forward, not looking back.
Yes, but you were the one that reached beyond, if you like, the narrowness of the review terms and into TYC. And do you accept that the failure to measure, implement and fund it properly has led to some of the problems that we're facing today? Because you do accept it was a forward-looking programme.
I accept it as a forward-looking programme. I only went into that because it had a direct bearing ultimately on the quality of care. The Minister himself yesterday, I believe, said that he hadn't got the funds yet that he needed to do that. I don't know whether that's the case or not. And as far as I can judge from talking to people about the implementation, it looks to me like a management solution is needed. There are lots of people involved. The leadership isn't clear enough. There's projects being initiated all over the place. It just needs to be gripped and driven forward in a much clearer way.
One of the things excluded from your report as well was, if you like, the entirety of the patient journey, some of the GP stuff and primary care aspects. And it's clear, for example, that the health service here doesn't know in real time, for example, what the length of GP waiting times. So if we don't have information, and you allude to the data issue, if we don't have the whole picture and the information, how can change be effected?
Well, I think one of my other recommendations is about data, and I think one of the quality gurus, Deming, said years ago, "In God we trust, everybody else should bring data." And I absolutely agree with you that you can't run a service without good data, and I hope those sorts of holes in our knowledge would be closed.
So you hope? We need more than hope.
Well, I'm giving you recommendations. I can only hope that you have the good sense to implement them.
The ultimate ambition of this report, if you like, and it's one I think that should be welcome, is the patient-centred focus. But given the absence of data, and given the absence of money to put the patient first, how can that ambition be achieved?
Well, I've recommended that you should do what they do in the States, which is to have an annual validated patient experience survey, and that funding should be determined by the results of that. I think that would concentrate the minds of the system very well.
But funding has got to be key to this in terms of shifting the money ultimately to the patient.
Absolutely, yes.
So how do we arrive at that point? And how do we get, and let's go back to the accountability part of this, how can the public be assured that this just doesn't become a review, if you like, or an analysis which allows cuts and it doesn't put the patient first?
Well, because the whole thrust of the report, I think, is away from the question of cuts towards providing a better service in the future. I think that's the clear philosophy running right through it.
Okay, thank you.
Thank you.
Thank you, Fergal. George?
Thank you, Chair. And first and foremost, could I commend the very professional consultants, doctors, nursing staff and health workers throughout our health service in Northern Ireland, and that's from the heart. And could I thank Liam for his presentation. And I think you've probably answered quite a bit of my question that I was going to ask you. It was in relation to the media. And maybe this is more for the department, how they handle the media from time to time. The media at times, I know they have a job to do, but they can be very negative, you know, week to week, from day to day, week to week, here, particularly in Northern Ireland. I think Sir Liam alluded to that. But from the department's point of view, how do you handle it from day to day? And it can't be easy.
Well, it can't be easy, and I think, as Sir Liam has said, you know, one of the prices worth paying for free media is that from time to time they land the odd blow on you. We do engage with the media. I think part of the issue where we have perhaps failed in the past is that we haven't done enough preparatory work with the media to help them understand. You know, an issue like Sir Liam's report, you can drift into it and miss the subtleties and nuances that are in it very easily, and I think we need to do more to highlight that, to signpost it, without in any way trying to handcuff the media. But I think it's a process of engagement, and it's a process of being mature enough to understand that we can't ever expect the media to be a sort of PR outlet for us. It's right that we're subject to scrutiny and critique from them, but I think, as we both said, I think it's a price worth paying.
Okay, thank you.
Hey, George. Paul?
Thank you, Madam Chairman, and can I thank you very much, Liam, for the work that you've carried out. I think recommendation 1, I would share some of the views that ultimately it should be for politicians.
Well, I hope you'll take the spirit of it, if not the letter.
I agree with the spirit. I think you should have a little bit more hope in some politicians to be responsible around this. I know I've had public meetings in my own constituency where I have said that Lagan Valley Hospital cannot be the Royal Victoria, it cannot be the Ulster, it cannot be Craigavon, and it would be wrong to pursue that agenda because you cannot spread the resources, and the outcomes are better for you to have specialists and specialist centres. So, and whenever you do explain, actually people do start buying into that. So I do think you will get some politicians, not all, but you'll get some who will be responsible, and you'll get some who will politicise the NHS. Ed Miliband wants to weaponise it, so I'm not surprised that there's politicians here will want to use it to have a go at a minister. I used to do it to Michael, or for the course to a certain extent. But it's how you insulate, I think, the system from being buffeted, that short-term incidents doesn't then alter the long-term objectives. And that's where I think we need to try and build that resilience in, that both the professionals and the management that have to deliver don't get so distracted by short-term. And that's why I noted your commentary around the media. I think, to be fair to UTV, they usually do give a balanced approach to it, in fairness to them. I think others would do well to read your report and give a better understanding of what's actually happening. The particular point that I wanted to ask is in reference to the Permanent Secretary. Your report says that ultimately, statutorily, Chief Executive of the Health Service, so to speak, but in terms of policy making, that's not widely understood and communicated. So what I would like to know from you is how should that look? How should we expect Permanent Secretary, Department of Health, to be running the health service from that Chief Executive point of view?
Well, this Chief Executive is relatively new, I think, so he does have the opportunity to look at all of this afresh. But I think it's difficult for somebody to be a Chief Executive of something as important as the Health and Social Care Service of Northern Ireland without being relatively hands-on with the system, being seen to be directing it, inspiring the staff, and being visible, and probably being public as well, letting the public see them and explaining the policies and promoting them and championing them and praising the staff and encouraging and motivating. Now, that is the classical job of a chief executive of a big organisation. But the governance is written slightly differently. It's a model whereby the chief executive is the chief executive in overall accountability terms, which is a behind-the-scenes form of accountability. And really, I think that's what lies behind those reflections that I made there, and to a certain extent they are picked up from the uncertainty that people felt about who was in overall charge whenever I talked to them. So it isn't a criticism so much as a feeling that you've got to make your mind up what model you want. I think you can do it all sorts of different ways, but there are attractions to the visibility, the champion, the explainer, the motivator model, and that is more difficult when you've got the governance structure written as it is at the moment.
Finally, Madam Chairman, TYC, given the budget reality that is there, we don't have a bottomless pit of funding, and that's not going to change. In fact, it's probably going to get worse. Can the change in TYC be delivered? Obviously, funding is going to always be an element, but you touched on how management processes need to get around TYC. So is there opportunity for TYC to be advanced by clear management process being put in place to drive forward some of that change? How much of it's dependent on funding vis-a-vis the delivery of the management processes?
Well, I almost said it in response yesterday to questions about that, and this will probably mess up all their thoughts about leadership and management. I would, if I was in charge of that, I would put in a Supremo for at least for a year to really get this going. I'd put one person accountable to the permanent secretary in overall charge and say, right, get this going. And because hospitals will suck all the money in any healthcare system. They just suck the money in. And until you start putting some lines in the red lines and innovating in some of the examples I gave you and starting to build up that infrastructure to stop the tide flowing into hospital, you know, it'll overwhelm the opportunity to implement this policy. So I think the media reported me say a rocket boost. Maybe it's not the right turn of phrase, but I think it needs to be gripped and moved forward in a very authoritative way quickly. And I personally, my management solution to that would be put somebody good in overall charge. As I once heard, I was once involved in a meeting with Mrs. Thatcher. I was chairing a visit to my region, and apart from the fact that she kept calling me Mr. Speaker during most of the meeting when I was chairing, she asked one of the clinicians there what she should do about a particular area of policy. And all he said to her was, put your best people on it. And that, she seemed to quite like that answer. And that really, I think, is what's needed here. Put your best people on it and get them to drive it forward managerially.
Thank you.
I think just before we move on to Rich, that's an important point. It brings up challenges as to why it's not driven by a person or your best people, as you referred to. But why would that not have appeared as a recommendation?
Well, because I think it's not for me to interfere, I think, in and provide suggest detailed solutions for the governance of and overall leadership of the programme. I've hinted at the areas that I think need to be, or I've said the areas that I think need to be looked at, but the solutions need to come from within, not from outside, because they'll have ownership of it then. They'll have ownership of it. If they come up with the solutions, they will feel that they've got to deliver. I don't know what you think.
Okay, Richard, moving on, there's a number of comments directly from members to yourself. Going back to the original recommendation one, the, you know, I don't need to rehearse it, but the public accept in advance recommendation from a panel. I mean, how serious are the department about that?
Well, Chairman, in many ways it's slightly premature to talk about the department's view of that, because as it was only yesterday the Minister published the report. The Minister now has made a call for evidence from the community at large up to the 30th of April, at which point, based on all the inputs received, he will formulate his formal response to that. So I think in advance of him actually investing the time and energy and reflecting on it and looking at the responses, but certainly we can see the intellectual rigour behind the recommendation, as Sir Liam has outlined. In many ways, it's an issue of politics for the Minister to take forward. I think, as the Minister indicated yesterday, he'll certainly want to engage with executive colleagues in the issue, but I think it's premature to outline a definitive response by the department.
Would you not accept, Richard, given even what you've heard today, that it turns processes on its head?
I certainly accept. I've heard that today, Chair. Yes, but ultimately it's for the Minister to respond to it, and the Minister hasn't concluded on his position on that yet. So I can't advise the committee of what his position is.
So there's no departmental view at this stage that recommendation 1 is a non-runner.
Chair, the report was published yesterday. In many ways, I think it resonates with the very point you're making, that if the Minister has said before he concludes on the way forward he wants to receive inputs from many parts of the community and the profession, to cut that off, I think, it very much reflects the point you're making. So he's not in a position to do that. As I say, he's only just published the report.
Yeah, but I mean, I don't know how long you've had the report in the department, or...
That's the end of December we received it.
And I think it's an important point to make as well, because Sir Liam has indicated today that, you know, this wasn't necessarily a recommendation that was coming from staff or patients.
Mm-hmm.
Do you accept that?
I absolutely accepted Sir Liam's recommendation as he's outlined today.
But do you accept that this wasn't based on a clear request or recommendation in terms of the consultation?
Yeah.
You do accept that, okay. Do you see, in relation to resourcing this, Richard, you know, and there's quite a few pieces of work included in this report, and you know, we have the Minister now committing to a range of reviews, of consultations, and even of legislative change going forward. You know, and within this, we have the review of commissioning, we have a review of whistleblowing, we have the conclusion of the morbidity and mortality review, we have a new system to review deaths, we have changes to the serious adverse incident system, we have the introduction of a new events list, we have an RQAA programme of unannounced inspections, we have a review of the 2003 Quality Improvement and Regulation Order, we have new legislative proposals for changing the non-acute services, and we have to design a new framework to measure patient experience. How and where does the capacity come from in the department to do that?
Well, Chair, I think some of the issues you talk about aren't particularly resource intensive in terms of taking forward, some of them more so. But fundamentally, it's an issue of prioritisation. I think we can all too often default to the position that we don't have a lot of spare money. The reality is we have the thick end of £5 billion available a year. It's about prioritisation of that money. All the issues you talk about fundamentally go to the heart of improving the quality and safety of the system. So that is money well spent. And I think a hard-nosed look at the prioritisation with which we deploy our resources is never more appropriate than in the context of the issues that have been highlighted in the report.
How do we start to prioritise those then? You know, what becomes, is it the review of whistleblowing? Is it the commissioning piece? How does that process?
Well, I mean, without getting into the absolute detail of it, Chair, I mean, various elements of them fall to various bits within the department, so they can be taken forward together. It's not as if the burden will fall on one small team within the department to take all these issues forward, and obviously we'll work with our partners and colleagues throughout the wider health and social care sector. So it's an issue just about taking them forward with all possible pace, making sensible, reasonable, pragmatic, prioritised choices and moving them forward. But we cannot deny the importance of taking them forward with pace.
So all of those that I've listed will be taken forward, is that what I'm hearing?
Yes, absolutely.
All of them?
Yeah.
Okay, there's a number of members have indicated. Pam first.
Thank you, Chair. First of all, could I just say to Liam, thank you very much for coming today, and very interesting. I don't have questions for you, I don't know, but you're very easy to listen to, and I could probably listen to you all day.
Thank you.
Fascinating. Questions for the department, really, and in relation to recommendation 6 and the duty of candour. Has the duty of candour legislation been addressed in any other part of the UK, first of all?
If I may, yes, certainly the proposals in relation to the introduction of the duty of candour certainly has been taken forward, as you know, in England. I mean, I think it's probably worth stating that there is already a professional duty on health professionals, on doctors and nurses and other health professionals in relation to candour with patients and clients. I think certainly the recommendation around a statutory duty of candour was one of the recommendations coming out of the Francis report. I think that undoubtedly candour is at the heart of quality and safety and quality improvement, and Sir Liam has mentioned the importance of that, and particularly in relation to engagement with patients and clients and the trust that they have in the service that's provided. I mean, I think that undoubtedly, in all healthcare systems, things do sometimes go wrong, and that is deeply regrettable, and sometimes patients are harmed, but it's absolutely essential that the population and those who use our services have absolute confidence that when such things happen, that the healthcare system and those professionals working in it will be absolutely open and transparent into relation to what those shortcomings were, where those failings were, the process by which those are identified, and as Sir Liam has mentioned, absolutely the learning in terms of how we're going to ensure that as a system and as professionals that those issues don't occur again. Again, as I was listening to Sir Liam speak, I was reminded of a quotation that I use often, that he used in 2005 at the World Health Organization, World Patient Safety Alliance, which is that, you know, to err is human, to cover up is inexcusable, but that to fail to learn is absolutely unforgivable. And I think it's only been absolutely upfront, open and honest with those who use our services that we as a system can truly learn and truly improve the quality of health and social care, and our patients and clients who use our services need to be absolutely confident in that.
Okay, thank you. Could you give us an indication of what any timeline for the introduction of that legislation?
Well, it's obviously, as the Minister has indicated in his statement yesterday, the preparatory work in relation to that has already commenced. He's asked officials, tasked us with beginning the initial stages of that. Obviously, it will require the introduction of primary legislation. Primary legislation, as you know, goes through the normal process and does take time, but there is now a clear commitment to that. As I say, you know, that will run its natural course, but legislation does take often in excess of, you can take sort of 9, 12 months or more, just depending on the complexity of it.
Okay, and from your response there, I take it then that the Department is convinced that legislation is the way to go in terms of encouraging more openness and transparency in the system? I mean, is there a danger that the introduction of legislation might give the appearance of having dealt with problems, when in fact there are cultural and systemic issues around openness that will need ongoing work?
I mean, I can certainly comment on that, but I'd be interested to hear Sir Liam's views on that as well, because I think that you're absolutely correct that some have a view that a statutory duty of candour may actually be a very blunt and legalistic instrument to ensure and safeguard that as health professionals and as a system that we're doing what we should be doing anyway in any event. And there are those that have concerns that it actually may be counterproductive in terms of either in terms of creating a system, which Sir Liam alluded to earlier, in terms of a system more under the microscope, or indeed a concern amongst some that they might be even less open and transparent than was previously the case. I think what it does is actually provide a legislative framework which reinforces and underpins what is absolutely the right thing to do in those circumstances. And I think that we should be absolutely ambitious in terms of ensuring not only that we're encouraging all involved in healthcare professionally to be completely transparent, and again, Sir Liam's report provides significant assurances in terms of staff's commitment to openness and transparency, including the SAI process, but also in terms of underpinning that in legislation, because I think that does give comfort not only to those who experience it in terms of patients and carers, in terms of behaviours and actions of staff, but also gives comfort in terms of that it's a statutory obligation on healthcare organisations and those working within it. But again, Sir Liam, you may have a
No, I think you've explained it very well. I'd agree with that.
Just on that point, Michael, if I may, the report itself, it's section 3, talks about between 3% and 25% of all hospital admissions result in an adverse incident. About half potentially avoidable. There's a big gap between 3% and 25%. What is the effort?
Again, Sir Liam, you've quoted the figures in your report, but we do know from studies right across the world that there is significant variability in terms of the assessment of the scale of avoidable harm. Interaction with, the truth of the matter is, as healthcare has become more complex, more technology. We are now treating and effectively patients for conditions for which they would have previously died, as Liam has said, because it is a life and death business at times. However, the downside of that complexity and that technology and the multidisciplinary nature of the engagement of teams of individuals is that sometimes patients do come to harm. That can be from a variety of reasons, and Sir Liam in his report has highlighted some things which are actually almost unthinkable in terms of wrong site surgery, in relation to prescribing errors, etc. And again, the literature and the academic literature looking at the frequency of that does actually provide a sort of a fairly wide range. The most important and telling point there is the 50% of that is estimated as being as avoidable. So, for a system that is about providing health care, should cause harm to those who come in contact with it, is somehow or other almost unconscionable. But that is the reality of modern health and social care. Sir Liam, I don't know if you want to comment on that.
Very briefly, if I may, the figures come from all the research studies that have been done around the world to investigate the number of cases of harm in the number of adverse incidents in hospital, both major and minor. The 3% came from the first study in the United States, and they used a very tight definition which was akin to medical negligence, really. So the threshold for calling something an incident was very high. The 25% was one which looked at everything, even the most minor. But when people look at all the studies that have been carried out, and there have been something like 20 or so around the world, they usually cite a ballpark figure of 1 in 10 hospital admissions result in some form of error, of which 50% or so are avoidable.
Okay, thank you for that. Kieran?
Thanks, Chair. I just want to follow on from your comments yourself, Chair, in relation to the number of reviews. When the Minister presented his statement yesterday, I did say, well, first of all, I want to complain. I think, Richard, correct me if I'm wrong, did you say that you had that report in December?
The 31st.
The 31st of December. Right, and we're nearly the 31st of January, and we only got that in our pigeonhole a few minutes before 10:30 yesterday morning, along with the statement. I think that's an atrocious way to treat a health committee, and indeed to treat the whole of the Assembly. 10 minutes, and you've had that line from December. Chair, I think that's crazy. That's crazy stuff. So maybe, and the Minister was, I did seem to be rightly embarrassed yesterday when he was challenged about why do we only get it 2 or 3 minutes before we go into the chamber to ask questions and discuss it and debate it. So maybe you'll answer that some other time, and maybe for a future we'll get better timing on it. But in relation to that, I did say to the Minister yesterday that we have reviews and reports coming out of our ears, and here we have 11 from your report, Sir Liam. And I've no doubt there's probably a dozen lying else in the department. And I think I'll table a question and ask the Minister how many reviews or reports has he got on his desk? Because, it's every time there's a mess made or something happens in the health service, we'll have another review, another report, and it builds up, There's something wrong there. Anyway, let's go on to what I want to ask, and Sir Liam, you might want to close your ears on this one. This is to the officials. Does the department believe that Sir Liam and the review team went beyond the terms of reference they were set?
I'd start if I may, Michael may want to come in. Firstly, if we could say, Chair, the issue about the statement not being available yesterday was an administrative mistake. It was planned to be more than an hour. So the Minister apologised yesterday on behalf of himself. I certainly apologise on behalf of officials, the members. It shouldn't have happened, and it is unacceptable.
It does. It's not the first time.
Well, as I say, I apologise for that, Chair.
And it does seem that it's maybe deliberate to avoid the members having questions prepared, real questions. I mean, I wanted to ask questions yesterday, and I think the Speaker shot me down because I was asking too many. But, it's not right that we get it 2 or 3 minutes before the time. So the question is, did Sir Liam overstep the mark?
From my own perspective, I absolutely believe that he didn't go beyond that. I think, as Sir Liam has alluded to on a few occasions, when you're dealing with issues of quality and safety, virtually everything in our system has a ripple effect that at some point drifts into those issues. So I think he's taken the review to some very pertinent. I mean, I think Sir Liam could have extended the review and covered a lot more ground that would have had a relevance. So I think he's focused on the big issues. Certainly, I see all of it as being germane to the challenge that was placed to him when the review was commissioned last year, and it's fundamentally at that quality and safety point.
Yeah, I mean, just very briefly, I mean, I think that obviously, you know, Sir Liam was asked to look at the governance of the HSE in the context of openness and transparency, its appetite for inquiry and learning, and redress in the context of the SAI reports and concerns around that process. And you'll remember the then Minister's statement back on the 8th of April in terms of establishing Sir Liam and his team at that time. I think that the fact that Sir Liam felt so compelled in terms of looking at the quality and the safety of health and social care in Northern Ireland to comment and recommend, you know, on the second theme, that actually the design of our health and social care system was actually the greatest challenge that we have in terms of maintaining the quality of social care was actually very telling. The fact that he also commented that it is that is causing the major stress on staff working in the front line, often feeling that they are not able to deliver of their best to the patients who they're providing care to, is also very telling. And I think that's something which we need to reflect on. And I think it is certainly entirely apt and appropriate that Sir Liam would, as Richard has said, comment on all relevant elements in terms of the quality and safety of health and social care in Northern Ireland.
You're happy that what we've got here before us is what Sir Liam was asked to do and has taken everything into consideration?
Yes, I'm happy that what he's presented to us is a very good analysis of the core issues that impact on the quality and safety of our system. Is again precisely what we'd asked for him.
Okay, thanks, Chair.
Thank you, Kieran. And Mickey?
Yeah, thanks. Again, back to transforming your care. In the statement yesterday, the Minister said, and I quote, "I am determined, even though we are working within a constrained financial context, that we must redouble our efforts to speed the implementation of TYC." Back in evidence given to the committee from the Department in relation to the budget in 2015-2016, the Minister had identified the implementation of TYC as his number 2 strategic priority, and there was a lack of clarity in terms of how TYC ranks in comparison to other areas of discretionary spend, such as elective care and pharmacy. Just really asking the Department to clarify that TYC is the top priority in terms of discretionary spend. And when the Minister and officials gave evidence to the committee in October of last year, the plan was to spend 15 to 17 million on the implementation of TYC in the coming financial year. I'm just asking, is that still the plan? And also in November 2014, in the approach to the current budget, or the budget for 2015-2016, we were advised that the Department was not in a position to advise of the projected shift in funding from hospital services to community primary services for 2015-2016. So it's just if you can clarify what that figure will be. And just in finishing, the Minister yesterday said in a statement in relation to TYC that the best change comes from the ground up, and I want to facilitate those at the coalface to play a fuller role in delivering the transformation, unquote. And how does the Department expect frontline staff to implement TYC when the resources aren't being committed? I know there's a number of questions.
There are, and I'll have a go at them, and if you'll come back to me if I don't pick any of the points up. Firstly, in terms of planned spend for 15-16, I can't give you a definitive number yet. We're still working through our financial planning processes. As you're aware, we face very significant challenges with an opening pressure of about 320 million next year, of which we've about 160 million additional funding and about 160 million of efficiencies we need to deliver. So within that context, we're still doing the numbers in that. Your point about the operational staff, it's one thing that has struck me in my relatively short time here, 7 months, having tried to get out and spend a fair bit of time around various facilities. the knowledge, passion, enthusiasm of frontline staff and the innovative capability of people on the front line is awe-inspiring at times. And I think at times the best thing managers can do is to capture that effort and innovation rather than try to necessarily bring a huge amount of quality to the game themselves. There's so much of it there. That's very much true of our approach to TYC. We will need some additional funding for TYC, and we've been consistent in saying that. And the 2011 report talked about £70 million of transitional funding. I think thus far we've received something in the region of about half that, so more remains to be done. I think Sir Liam made the point very well about the need to focus energy and attention on this too, because notwithstanding a shortfall in transitional funding, we can make progress through focusing attention on it, through building in the capacity and motivation of staff on the ground. So there's lots that can be done. I think we need to reflect just going into 15-16 and that what is probably the most challenging financial year thus far. I think it would be deeply frustrating if all our energy and attention just manifested itself in achieving a balanced financial position and not having to take the extreme sort of contingency measures that we had to do at the tail end of 2014. The reality is if we do nothing but stand still and don't actually find the space to intervene and change the system, every year will just be the same in dealing with crisis and finding more and more extreme ways of managing pain. We need to start changing the direction of the oil tanker.
Well, thanks. I mean, absolutely commend frontline staff in the health service, and to be purely parochial for a moment, having visited Daisy Hill before Christmas and met staff, frontline staff, their commitment, enthusiasm, the work that they do under extremely pressurised circumstances can only be commended, and they continue to do that. And the support that they need has to be found. Transforming your care, as I said, we've been told a vision without action. It's time the action was put into place, I think.
Well, I mean, I take the criticism about TYC because it's not where we wanted to be, but there has been a fair amount of action on the ground. I think we need to collate and capture that, and as Liam said, maybe think about giving it a much more visible driving force behind it to bring it home the way we want to.
Thank you.
Can I just clarify on that, Richard? Are you indicating now, or can you maybe clarify now that in terms of discretionary spend, that TYC will be the priority?
Well, nothing has changed. I think Mr. Brady quoted the Minister's comments, and nothing has changed when he talked about TYC being a clear priority for him.
But it was a number 2 priority.
Well, I mean, that was the position he articulated on the day. It's the issue then about within the financial position, because I think, as we've talked about before, the difference between discretionary spend and the statutory obligations on us to provide services.
We can't clarify at this point if TYC will be top priority in terms of discretionary spend.
It hasn't. The position hasn't changed from the way the Minister outlined it when he was at the committee. The issue then, sorry, if you're wanting to explore how that manifests itself in the funding allocations, that depends on just the outworking of the overall financial position, because it still is discretionary spend. But at this point, we've debated it before, Chair, the difference between prioritisation and obligation, and something can be number 1 priority, but if there's no statutory obligation to do it and there's statutory obligations to do other things.
But there's a strategic policy direction that we have all signed up to in terms of transforming your care, which we were told would be the issue, the policy piece that would address some of the issues that Sir Liam has reflected in his report.
But Chair, the point I'm making, and I'm not suggesting that TYC won't be taken forward. The issue goes to the pace at which TYC can be taken forward, but the reality is, within a budget which is clearly less than the Minister feels he needs to run health and social care next year, given the range of statutory obligations upon him, they have to be discharged first before he can find any funding available for discretionary priorities. That's the simple reality.
But the question I'm asking you, and I accept that there's constraints in the system. I also accept the fact that we need to deal with those constraints, but that we have done what we can in terms of the protection of the department there. But my, I think, clear question is in terms of the discretionary spend. And, what assurance can we get TYC will be the priority, for example, over elective care? How do we know?
Well, the Minister sat in front of the committee and said the TYC was a priority.
Okay, it was number 2 in terms of overall priority.
I'm sorry, Chair, I don't have the authority to change the Minister's priorities. The Minister indicated then that was the prioritised nature of it. I'm just saying that remains the position.
Okay, a number of comments. Rosie is next.
Or Margaret Catherley. And I was just wanting to explore some thinking about how maybe things can be done better in terms of resources. And diabetes was mentioned earlier, and Liam, you outlined an example of how things might be done better. And I think failure maybe to learn from that example might fall into your unforgivable bracket, Michael. But we're all talking about diabetes as the big threat that is just increasing all the time, and it's going to be the biggest burden on the health system. And a lot of it is very manageable and maybe avoidable with good education. Now, it was referred to earlier on about how some people are very good at just obeying the rules, and there are very simple rules for people with diabetes that might be easy for some people to follow and maybe not for others. But some people are just better than others at just doing the right thing. But people are all different. So my question is, Michael, and I'd be interested, Liam, also in your views on it. What other ways are there, or have you looked at, or are you thinking about getting the message through to people, giving the people hear advice or accept advice or learn in very different ways, so that the one-size-fits-all doesn't work? And given the nature of diabetes and the big threat that it is, it's important that we try our very best to get the message out in as many different ways as possible, so that as many people as possible will learn the lessons and hopefully avoid it or manage it successfully.
Yeah, I mean, a very good question. It's a good example of a long-term condition that's going to be around for quite some time, and Sir Liam gave an example of that in terms of the importance of actually patients being empowered in relation to self-management. As you recall, the then Minister requested that I would undertake a review of diabetes services in Northern Ireland, which has been completed. That was taken, it was involved working with Diabetes UK and the Northern Ireland branch of that, and a range of health professionals here in Northern Ireland. And it looked at a range of issues, both in terms of the public health messaging in relation to avoiding diabetes, in terms of particularly type 2 diabetes, in terms of what we're doing around public health, and the new public health framework, Making Life Better, and what we're doing on the obesity prevention strategy, right the way through standardising patient education programmes, self-management programmes, right the way through to actually looking at novel interventions and treatments for the management of diabetes, making recommendations in terms of the development of a register for all people in Northern Ireland with diabetes, the establishment of a diabetes network, along the same lines that Sir Liam was outlining, with a focused leadership working and advising the Health and Social Care Board and Public Health Agency around the appropriate models to commission for diabetes care across Northern Ireland that will actually improve the quality of those services and the outcomes for those patients using it, and the experience of people living with diabetes of those services. Now, that report has been completed. It has been shared with those in terms of taking it forward through implementations. Back to the point that the Chair made earlier about capacity. The same officials that in that work have been involved in the response and developing some of the planning around Ebola, for instance, and that has been slightly delayed. But very happy to share with the committee in due course the outworkings of that and the plans to take that forward, because it's a crucial area in terms of the improving the outcomes for people living with diabetes in Northern Ireland, and it is a major cost to health and social care here in Northern Ireland and at the UK. I think the estimates are some 12% of healthcare expenditure is in relation to dealing with diabetes and some of the complications, whether that's end-stage renal disease, retinopathy, is problems with eyesight and vision, and again, through better control and better self-management and better support of people living with diabetes, then there are significant savings to individuals in terms of complications, but also in terms of healthcare costs. But that requires a different model. You know, again, as Sir Liam has alluded to in his report, it requires a model which actually involves bringing patients and users of service into the tent in terms of how we design and commission those services. So they co-produce those models with it, and we have that maturer relationship with isn't the big doctor up here and the patient here, that it has to be that partnership.
Michael?
Yes, thank you, Chair. Just very briefly, we talked, first of all, can I make a comment about the panel? I know it's an international panel of experts. It seems to me that you need input in that. I don't think an international panel of experts, brilliant as they may be, is going to be sufficiently connected. And the other play I would make to you must involve staff side. You have 70,000 people working in the system. This ain't going to go without them. So they need to be very much involved in all of this. It refers, Richard, to talking about TYC, and I think it was Mick was asking a question and about the money, and you're saying, well, we'll have to prioritise out of 5 billion.
Mm-hmm.
Now, I understood your deal was 4.6.
So I think I said the thick end of 5 billion.
No, I didn't hear the thick end.
Sorry.
When I heard 5 billion, I thought,
oh, no, sorry.
Somebody's not telling us something here, you know. Has
no, sorry.
Write a check.
Wouldn't be a first. Oh, sorry.
So it is. It's just that looking at the weights, the worst 4-hour weights in the UK. We also have our weights as far as a number of our specialities are concerned. And as I understand, we're going to get the figures again mid-February, but the last ones, I think there was about 16,000 in waiting beyond where they should be. And when people are waiting too long, they come to harm, and we know that, and they're in distress. How are you going to fix this if you can't get up beyond? Because the 4.6, as we've told, as I said 4 years ago, as Edmund Poots eventually said, as Jim Wells is now saying, there's not enough money in the system to run the system. So how are you going to fix this? How are you going to make this right, TYC? How are you going to do this and evolve along the direction that Liam saying we should go, and at the same time fix the stress in the system, because there's clear stress here.
Mm-hmm.
And that is, now I know you're brought in because you're the money man out of DFP, as was your predecessor. So he wasn't able to get a printing press. I'm just wondering, when I heard the 5 billion, I thought, aha, he's... There's
if only,
because somebody has to work out that just the pure politics of this. Somebody's got to write a check.
I think the point you make is very true, that those weights that you allude to, they're not going to improve unless we change something, and they're going to continue to decline. I would, from my perspective, as much as additional money would be very welcome, I think additional money without systemic change is the wrong way to go in this. I think we need both. We need some investment, and we need to find a new and better way of doing things. Now, I think there's a huge amount within this report that offers us a roadmap to do things differently. I know there's some points that the committee may or may not accept, but I think the process of challenge, reflecting on how we currently do things, the acceptance that what we've been doing up to today isn't working as well as it could be, and that process of challenge, reflection and change. But we must drive change, and those weights will just continue to erode throughout the rest of this year and the next year, Mike.
No, absolutely, and I think your point around the weights for elective, unless we, I mean, there isn't the capacity and capability within the health service at present, and the fact that we've had to turn off the independent sector, as we indicate, we should outline to the committee when we were here previously around the implication of the living within our budget, would be very profound in terms of people waiting at home, and many times waiting at home in pain and discomfort. And I think also your point around unscheduled care is also well made, and we again went through the details of that when last giving evidence to the committee. I think that the system certainly over the winter period has been under a significant amount of pressure. We did see that 7.5% increase in emergency department attendances. We did then see that dip, as you alluded to in the last session. We've given evidence where ED performance, 4-hour performance, did dip below 80% to 79.8. Although in the context of a 7.5% increase in demand, one might have expected that dip may have been more than that. Now that, again, is disappointing. Last year did see the lowest number of people waiting more than 12 hours, and that should not be our benchmark, absolutely not, in the last 5-year period. I do anticipate that the figures, given the pressures that we've seen, throughout even the first number of weeks in March, where we've had a further 6% increase in emergency department attendance, a further 3.5% increase in relation to ambulance attendances, and those generally convert more into admissions because they're sicker patients by and large. And we've also had a 5.9% increase in people directly through into hospitals. That might be our frail elderly, it could be patients with acute MIs, etc. So we are likely to see, I suspect, a certainly not significant improvement or change in the 4-hour target in the latest statistics, which will be released, as you say, shortly. And I think Richard's absolutely right. It is a combination of us doing things differently, and indeed through the work that I'm taking forward with Charlotte and engaging with the rest of the health and social care system in Northern Ireland. We are, through the Unscheduled Care Task Group, looking at different models, putting those different models in place. I mean, we had on Monday of this week a fascinating presentation from the Northern Ireland Ambulance Service, where in relation to the example that Sir Liam referred to in relation to hypoglycemia and diabetics, they were proposing a different model for the management of frail elderly people who fall at home. There are something in the region of significant proportion of frail elderly people attend our ED departments. We can get a different model in place which actually allows us to manage those patients at home rather than coming up to our emergency departments. So I think you're absolutely right. So it's quite a combination of using our resource to our best of our ability, and if there is more resource to have, yes, we can use it. But also, as Richard has said, that systemic change that's required that Sir Liam has also pointed to in his report.
But if you're one of these patients, for example, as I understand, you've stopped elective spinal surgery, isn't that right?
Well, I think
there's been emergencies only.
I think there's been a pause on a number of.
You've lost 4 orthopaedic surgeons, I think, is that right?
Well, again, as Chief Medical Officer, the detail of that obviously will be with the Health and Social Care Burden Specific Trust. But I think that there have been.
If you're one of these patients sitting waiting.
I agree.
And you're in some pain and some distress, and how long are they going to have to wait? Because they can't wait for systemic change, and they can't wait for all the different ways of working and whatever. What you need is somebody to write a check to allow you to buy the procedure to sort them out. It's not right, and that's just, and you have thousands of folks like that.
Well,
on the waits.
Sure, and I mean, I've given evidence to the committee before in terms of the pressures on the healthcare in Northern Ireland, and my concerns, and indeed the then minister communicated my concerns to him in relation to the consequences of the challenges that we face around our budget. I have those concerns, and we are seeing the manifestation of that. But as Richard has indicated, we have the resource we have. Our challenge and task is to live within that resource and provide the best service that we possibly can, and at the same time continue to seek to improve that service by using that resource ever more efficiently. I think that's a big ask, it's a big challenge, and unfortunately, as the Minister alluded to at the start of January, the issue that's going to dominate health and social care over this year is going to be the resource allocation and the budget that we have to deliver, and there will be some tough choices, and you have highlighted some of those. You alluded to earlier the direct access physiotherapy. It's not that it's been abandoned, but if indeed we have excessive numbers of people waiting for physiotherapy, we do need to prioritise access to resource. That's deeply regrettable. It's not abandoned, but we had to pause that whilst we deal with the demand and the backlog of patients requiring physiotherapy.
But is that not, sorry if I might, Michael, is that not counter-strategic? You're talking about doing things differently, and then we pull a project that...
Chair, I'm on the record when I was at the committee previously in relation to my concerns about some of the implications. Richard has been is on the record in terms of the decisions we made are the decisions that we needed to make in relation to the flexibility that we had in terms of uncommitted resource. And to say that all of these decisions at that time were strategic, or what we would have wished to have done in a different budgetary situation, those clearly would not have been the decisions.
Michael, had you finished there?
Finished,
yes, sorry
thank
for
you.
jumping on it. Fergal?
Thank you very much, Chair. Thank you. Richard, we talked earlier on about this illuminating the landscape, if you like, and identifying various constituencies, some of which are transitory, if you like, in terms of people taking an interest, either as individual patients or campaigning around hospital closure, whatever it happens to be. So if you discount those, that leaves you then, if you like, the department with the responsibility, the day job with responsibility. So how do you react to what, in my view, and in view of considered audiences out there, is a damning indictment of the department's stewardship of the health service?
Maybe, if you forgive me, could you help me understand what bit you think is a damning indictment?
Well, there's a question in here which I think is fascinating, that it's in, the fact that it's in, on page 16, who runs the health and social care system in Northern Ireland? Is that not, the fact that that question appears in this report, not a damning indictment in itself?
Well, I'm not sure that it's a fundamental question that appears in the report, as opposed to Sir Liam highlighting something that is, by any analysis, suboptimal in the system. A system this large, there is a lack of clarity. I think it's a valid critique. I don't accept it's a damning indictment. And I think it would be worth much longer debate about what is the implication of that perceived lack of people knowing who's in charge. One of the issues that I've inherited, and I think I've mentioned to the committee before...
Sorry, can I just remove the inheritance aspect of this? I'm asking about the department's ongoing and long-term stewardship of a system that is clearly failing the public. Not your most recent appointment.
The report doesn't say that either.
Pardon?
It doesn't say it's failing the people of Northern Ireland either.
Right. Can you say then, it's somewhere in the system for needs to be assessed, services, plans, funds allocated. Whichever part of the system is responsible for this must be sufficiently resourced. You might not find those specific words.
Read the conclusion.
Overall,
the chair, please.
Sorry, Chair.
If he would let people finish when they make their point rather than headline grabbing.
Sorry.
Sorry, Paul.
Ahead,
Was you interrupted me?
Yeah.
So, learn your own lessons, please. Sorry, Chair. To address the point.
Yeah, the point is, in terms of the system, that this lack of who's in charge, I'm not sure it's that expressed in those terms a fundamental issue in terms of the day-to-day provision of healthcare. I think it's a challenge for us in terms of leading us through a process of transformation of the healthcare system. The reality is that our healthcare system operates, and as Sir Liam recognises, and I think it's a very astute analysis, there are far too many silos. Within each of those individual silos in our healthcare system, people are in absolutely no doubt about who is in charge of their world as they know it. It will be the chief executive of the organisation which they operate. I think the challenge for us, and it comes through not specifically in what Sir Liam said, that if we want a whole system approach to a range of issues, we need to break down those boundaries, and we need to act and behave as an integrated health and social care system with clear leadership of the system. And I think that's the point that Sir Liam is highlighting, that we need leadership of the system, not individually.
Yes, and what I'm saying is, how does the department react to the fact that Sir Liam has been able to arrive at those conclusions? This isn't a system that's... You
asked me how I react. I tried to explain what I was doing, and you cut me off because you said you didn't want to know.
Oh, no. You continue.
What we are doing is as a first step, we've created, which hasn't happened in many years, a senior management team of the health and social care system in Northern Ireland. We're all trust chief executives, the chief executive of PHA, of the board, myself. We meet in that forum not as representatives of our individual organisations, but as the senior management of the health and social care system, a group that I chair and I give leadership to, but with joint leadership from my colleagues at Trust Board and PHA level, who are also giving very clear and decisive leadership together with me and separately in their own individual organisations. I mean, it's difficult for me to make an assessment of this, and Michael might want to add something. The fact that we've started those meetings, Trust Chief Executives are saying to me there is a better sense of the whole systems approach to the issues. I think the work that we're doing and the point Sir Liam made about the review of commissioning, the review of administrative structures that the Minister announced before Christmas, where we're looking at how our structures within the system interact with each other to remove duplication. All those issues, I think, are starting to get traction, and that's how we will address this issue.
But with respect, I don't think you've actually answered the point.
Well,
and the system that a man who has authority that Sir Liam Donaldson has been able to ask a question about simply who is running this system, obviously points to long-term flaws in the system. He's able to point to a TYC plan that hasn't been measured, implemented or funded, and you're not able to tell us today that that will change.
No, I don't accept that. I'm not telling you. I'm outlining for you exactly how we are seeking to change that. Your introduction to this was it's a damning indictment for the department, and one of the points you make is that TYC hasn't been properly funded. That's an executive decision. The department can only deal with the resources allocated to it. And we have expressed previously our frustration, as the Minister's on record with his frustration. But all of these issues, this leadership point, I think, is an absolutely valid point. But I don't think it is the fundamental plank on which all these other issues are built.
With respect, and Mr. Jimsey is here to represent this point. He may not want to point, but he pointed out at the time that the system needed more money. The TYC plan was developed outside of a budget and was to be funded only out of monitoring rounds, so it was flawed from the start.
Sorry, I didn't get a question. Sorry.
I'm making a point, contrary to the point that you're making. Would you agree? Well, I'll make it into a question. Then, would you agree that that's the case? And that was the case?
I don't know. I wasn't in the department when the TYC report. The issue about it was to be funded out of. I don't think the TYC report specified that it was to be funded out of in-year monitoring. The TYC report recommended that it would need 70 million of transformational funding to fully implement it over a 3 to 5 year period. I suspect the report, and I haven't gone through and checked precisely, I suspect it did not use the words monitoring around anywhere in the report.
No. It was conceived and came after the budget. It could only get money out of other sources, which was the monitoring rounds.
Well,
so it never had a chance and has never been properly funded out of those monitoring rounds ever since. Did you apply for funding for TYC in the January monitoring round?
I don't think we did in the January monitoring round, because the January monitoring round, you're constrained by your capacity to actually spend money, and there's only a couple of months left in the year. And notwithstanding, there was a clear signal there would be no money available.
So it didn't get any money?
The money wasn't allocated to TYC, not just because we didn't bid for it.
Okay, can I turn on to another issue, which is around the system to review deaths to complement the role of the coroner? Don't we already have a system? And shouldn't deaths be referred to the coroner in cases where it's deemed necessary?
Yeah, there's statutory responsibility, Section 7 of the Coroners Act, and there is statutory responsibility, and indeed, as the then Minister announced back in April, there was a look-back exercise of all SIIs between 2009 and end of 2013. The purpose of that was to look at the read-across between those SAIs, the complaints process, and also to ascertain the involvement of families and carers in relation to that process, and to actually provide assurances in relation to the information being conveyed to the coroner. That review has been completed, and it will be published in February. Sir Liam did have an opportunity to consider the findings of that RQI assurance of the process, and has commented on that in his report.
And would what you're proposing require new legislation?
No, it doesn't.
Had you taken any consideration of the Attorney General, John Larkin's proposal that we would have outside scrutiny through his offices?
I think I'm aware of the Attorney General's comments on that. Indeed, I have met with the Attorney General in the past in relation to this, yes.
And will there be any need for legislation, primary or secondary, in relation to quality improvement and regulation order in relation to the regulation of acute health care providers?
There will be, yes.
Which, primary or secondary?
It will probably be requiring primary legislation, and obviously the underpinning regulations will have to be developed from that as well.
What will be the situation in relation to non-acute services?
Well, in non-acute services, again, my understanding is that that will also require some changes. I believe I'm not precise on that point, but I think it's in secondary legislation into regulations. But again, happy to confirm that with the member.
Okay, thank you. Thank you, Chair.
Okay, members, thank you for your time, taking the time, for yourself, Liam, and sharing this with us. Obviously, there's a number of questions, and I suppose by way of comment, the information that we've received today that we would expect, I think, Richard, to hear from the department as to what they're going to implement in terms of the recommendations that you've made. But I thank you for your time today. Okay, members, moving on to item 5, which is the review of workforce planning in the context of transforming your care. Referring members to page 11 of your meeting pack, which is the draft terms of reference for the review. That was an important piece of work. Just asking members at this point if there are any comments on the terms of reference, or are members content with what's being proposed?
No.
Okay, and just advising members that Research Services will brief the committee next week on a paper they have prepared for the review. Item 6, members, is the Forward Work Programme. I'm just asking members to note the Forward Work Programme. 7 is Matters Arising. There are 3 items under Matters Arising in the meeting folder, suggesting that they're all noted unless members advise otherwise.
Well, Chair, just to say on the correspondence in relation to the IVF.
Sorry, we're going to move on to correspondence now, yeah. Assistant Matters Arising?
What is it?
Yeah, she means 7 point.
Okay, sorry, it's under Matters Arising. Go ahead,
Yes, it is, sorry. I'm confused there myself. I was just to say that doesn't appear to be a hugely extended cost for the full cycle, so I don't know whether I presume we'll be sending a copy of this anyway to the APG.
I think we should.
Yeah,
I think we should.
And would it be worth going back and saying, asking if there's any chance that we could move on to one full cycle as an interim measure, given that the cost doesn't. You're talking between 200,000 and 300,000 for a full cycle.
It's certainly not the figures that had been previously almost suggested or estimated. But yes, I think we should forward that to the APG and seek clarification as to next steps in terms of moving to the next stage on the department. Members' agreement?
Yeah, Chair, on the Access to GP Services report, on the Patient Client Council, would there be any merit in meeting the Patient Client Council to discuss GP services, because of the interest that has evolved in the last few weeks about the future of GP services and the difficulty in employment and new recruits, etc.
Okay, I think it's an important piece of work. I'm suggesting, Kieran, that we invite them along to the next stakeholders engagement specifically on that piece of work.
Okay.
Okay, thank you. Members, under correspondence, and there are 13 items of correspondence. Just in terms of time, I'm just going to draw attention to a number of them. Item 8.2 on page 34 is a letter from the Minister advising that he's seeking executive approval to launch the public consultation on minimum unit pricing for alcohol. Are members content to note that?
Right.
Page 45 is correspondence from the Education Committee, and they're hosting a joint stakeholder event with this committee on the 18th of March on health services which provide access to the education curriculum for children with special educational needs. There's a list of organisations and schools who have been invited to attend the event, and they're detailed. Are members content to note?
Right.
Page 57 is correspondence from the Chartered Society of Physiotherapy, and we had raised this issue previously with the department, expressing their concerns. I think they're shared with the committee in relation to the department's decision not to proceed. And I heard Michael McBride today saying it hasn't been abandoned. Not to proceed with the pilot for self-referral for physiotherapy. The Society have suggested that the committee calls the Health and Social Care Board before us to explain the position. I think it's an important issue. I think it's an example of that shift left. I'm proposing that we invite the board to a meeting within the next few weeks to discuss.
Great.
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 Thank you. Page 59 is a letter from Derry City and Strabane District Council regarding the feasibility of using the White Oaks Rehabilitation Centre, which is in Donegal, as a detox unit on an all-island basis. There's a significant public petition. My understanding is 52,000 people have signed the petition in relation to a detox centre. I am suggesting that we would write to the department to seek an update on the latest position regarding this proposal. It's also useful to point out that the Minister is meeting with a delegation from the Addiction Task Force in the North West next week to discuss this going forward.
Great.
811 is a letter from CPL Industries regarding smokeless fuel and the health benefits associated with it. They're seeking to meet the committee, again suggesting that they're invited to the next stakeholder event.
Great.
813 is a letter from Save the Mid seeking a meeting with the committee, suggesting again that they are invited to the next stakeholder event.
Great.
Item 11 is an SL1, the Firefighters Pension Scheme Regulations. It's in the tabled items booklet. Refer members to page 63 and to item 8.3 under correspondence in your main pack. Effectively, the department is proposing to make a statutory rule to establish the Firefighters Pension Scheme membership and funding arrangements. The Fire and Rescue Service and the Fire Brigades Union support the policy proposals. Are members content that the department prepares the statutory rule?
Great.
Item 9 is any other business. Do members have any other business? And item 10, the date and time of next meeting is Wednesday the 4th of February at 2 p.m. in the Senate chamber. Thank you.